Greetings, everyone. We're embarking on our lecture on trauma, burn management, mass casualty, and biological warfare. This encompasses a very broad array of topics clinically relevant to anesthesiologists. And of course, each one of these topics can encompass an entire day's worth of lectures. So we're going to try and focus, again, more on the specific areas within these clinical domains that have been tested specifically on the ABA written board exam. So to that end, we're going to basically put our crosshairs over management of patients with head injury, spine and spinal cord injury, abdominal injury. So related to trauma anesthesia, the ABA has spent some time emphasizing principles related to transfusion management, cervical spine injury, spinal shock, head injury, abdominal compartment syndrome, and cardiopulmonary injury. With respect to burn injury, they have repeatedly tested concepts related to carbon monoxide, cyanide, and hemoglobin poisoning. And biowarfare tends to focus most of the time on organophosphate pharmacology. So we'll begin with head injury. Of course, there's a very high mortality rate with head injury, and 40% of deaths related from significant trauma are related to neurologic demise. The major factor is ultimately related to secondary injury, which is tissue hypoxia, cerebral hypoxia, as the process of lactic acidosis, free radical generation, and the release of excitatory toxic amino acids like glutamate ensues. It ultimately dysregulates the integrity of neuronal cell membranes, you breakdown of these cells, and you get a large quantity of sodium, calcium, and water into the cells, resulting in cerebral edema and neurologic demise. So the early complications of head trauma, as you can imagine, involve egregious degrees of intracranial hypertension, brain herniation, and seizures, in addition to neurogenic pulmonary edema and cardiac dysrhythmias round out the core central vascular effects of significant trauma. Which of the following is false regarding the Glasgow Coma Scale? So the correct answer is B. Upper extremity flexion is actually a better prognosis than extension. This is a so-called difference between decorticate versus decerebrate posturing. You should, of course, spend some time acknowledging yourself about the Glasgow Coma Scale. This is, of course, something that's used to grade the degree of neurologic injury or integrity of the neurologic system, and is divided into responses related to eye-opening, motor response, and verbal response. So I'm not going to read the list off to you, but definitely take some time to know what score is appropriated for each response so you can answer these questions correctly. So basic management strategies for patients with head injury involve those maneuvers that reduce intracranial pressure and normalize cerebral perfusion pressure and oxygen delivery to the brain. Now, the Brain Trauma Foundation and American Association of Neurological Surgeons have published evidence-based guidelines for this, and the primary therapeutic goals include normalization of systemic blood pressure. No longer is it advocated to hypernormalize or increase hypertension or high blood pressure for these patients, which promotes cerebral blood flow increases and worsening ICP. Maintaining sufficient oxygen tension in the blood, reducing ICP to less than 20 millimeters of mercury, and maintaining a cerebral perfusion pressure of anywhere between 50 to 70 millimeters of mercury. Above that level, the former standard, as I alluded to earlier, is no longer advised. Again, it can be deleterious in terms of the increased cerebral blood volume and ICP that can result, as well as an increased incidence of ARDS from fluid overload. Head elevation is part of the mainstay of management, and sedation and neuroprotection with sedative hypnotics is given as necessary. In severe cases, cerebrospinal fluid can be drained through a ventriculostomy catheter. And hyperventilation therapy is typically instituted initially for no more than around 24 hours or so, and that's aimed at reducing the PCO2 tension to no less than 25 to induce vascular constriction of the cerebral vessels, and hence reducing blood volume in ICP. Anything less than PCO2 25 and you are risking cerebral hypoperfusion, which of course would not be advantageous in this situation. And you probably want to temper and transition out of this therapy beyond 24 hours after the brain starts to recalibrate to a new set level of CO2 tension and brain acid level. So ultra-high dose barbiturate therapy, barbiturate coma, is of no value in routine management of head injury because, as you can imagine, with high doses of these drugs, you can get hypotension. The maximal reduction in CMRO2 that you get with thiopental is 50%. So going to excessive doses beyond that range is only going to result in cardiovascular derangements such as hypotension. What has been considerably controversial in the management of head injury is, of course, the management of plasma glucose levels. We know that excessive hyperglycemia is maladaptive for the head injured patient. However, very conservative management of normalizing glucose levels may have deleterious effects in and of itself. There may be unrecognized troughs in glucose levels that in and of itself are very maladaptive to the head injured patient, as you can imagine. I'll spend some time talking about spine and spinal cord injury. Current guidelines for patients with spine injury in terms of the initial assessment include identifying the absence of neck pain or paresthesias and a lack of tenderness to palpation during voluntary flexion and extension of the neck in a neurologically intact and conscious patient. These are considered sufficient for ruling out cervical spine injury. Although previously we thought that alcohol intoxication, distracting associated injuries may alter this approach, so long as the patient is able to focus and concentrate on these methods of assessment, they are considered sufficient. So depending on the type of deficit, spinal cord injuries are categorized as complete or incomplete. So the idea here is that if you have obliterated any sensory perception over sacral dermatomes, that is highly suggestive of complete injury. And that's important because under those conditions, the possibility of significant neurologic recovery with complete injury is very low. Okay, whereas there's very optimistic functional restoration of patient's spinal cord function in incomplete injury. Now, what sort of makes this a little tricky is that initially there's a lot of spinal cord edema that occurs with spine injury that may be severe enough that it causes compromise of the sacral dermatomes and sacral distribution of nerves. So it seems like the patient has complete injury, but after the first day or two, a lot of that edema may resolve with management, and the true type of injury declares itself, and the patient actually may have sensation intact over the sacrum and lower distributions and dermatomes. So that's why it's important to serially evaluate these patients neurologically. So, and this is what I say in this slide, basically absolute flaccidity and loss of reflexes resulting from that spinal cord edema really precludes your ability to distinguish between complete and incomplete injury. So initial aggressive management of reducing nerve edema and injury is critical so that you can allow the patient a fighting chance to declare what the true degree of injury is and then proceed with further management as indicated. So one of the things you should be aware of is, in terms of semantics, is the difference between spinal shock and neurogenic shock. The two sound very similar, but just so you have it clear in your mind, in this slide what I'm talking about is spinal shock, and this is what I've been discussing so far, which is that edema that develops in the spinal cord, which basically compromises the ability for nerve cells to elicit action potentials and causes significant compromise of neuromuscular function. That's related to spinal cord edema. That's spinal shock. Neurogenic shock is very different. Neurogenic shock is a term that's referring to the hypotension, the cardiovascular consequences of the ablation of the sympathetic nervous system. Okay, and that's what you see on this slide. So hypotension, bradycardia, this is a loss of vasomotor tone and sympathetic integrity of the heart and the circulation as you've compromised the sympathetic chain. It usually presents itself, as you can imagine, after high thoracic and cervical injuries. This also tends to improve within a 3 to 5 day time frame. So know the difference between spinal versus neurogenic shock. So if cervical spine injury is suspected, of course you immobilize the patient and use manual inline stabilization of the neck. If the patient has thoracic or lumbar injury, you want to be careful not to manipulate them too much. We utilize log rolling maneuvers to transport them from the gurney to the operating room table. Signs of respiratory distress, arising PCO2, things like that mandate immediate management of ventilation and possibly require positive airway control ventilation with tracheal intubation. Severe bradycardia and dysrhythmias can be common as a result of unopposed vagal activity, either spontaneously or due to provocative interventions such as tracheal intubation. And that's really due to loss of that sympathetic tone from ablation of all the sympathetic chain. So high-dose steroid therapy is something to be considered with spine injury, and this was kind of the mainstay of therapy for a long time. And when I say high dose, I mean excessively high dose. I mean a bolus of 30 milligrams per kilo within 8 hours of injury of methylprednisolone, for example, followed by 1 hour or infusion for the next 23 to 47 hours. And the idea here is that although you would think from a mechanistic standpoint that this would make sense because you're reducing a lot of that spinal cord edema and it improves your ability to assess, once that edema resolves, what the true degree of neurologic function is. There's a variety of studies, most notably the NACIS-2 and NACIS-3 trials, that more than anything else suggested that maladaptive effects of steroid therapy were more likely to occur than an improvement in morbidity due to the prompt treatment with steroids. It's been hard to reproduce a lot of this data with high-dose steroid therapy with spinal cord injury, which is why this has come under fire and called into question significantly. So as you can see, there's a host of effects, as you well know, from using steroid therapy in patients, not the least of which include infection, pneumonia, days spent on a ventilator in the intensive care unit, and overall mortality. Respiratory complications of spinal cord injury. So definitely something to review. Understand what happens from a respiratory physiology standpoint when patients have cervical spine injury. And now, first think about this. You, of course, worry about really high cervical injuries that compromise the phrenic nerve, in which case these patients are unable to ventilate. And of course, that would by definition mean you have to provide ventilatory support for these patients with tracheal intubation, positive airway pressure ventilation. So a little bit more elusive is the idea of what happens to these patients from a respiratory standpoint when you have the phrenic nerve intact. Okay, so if you have a lower C-spine injury, you still have significant respiratory compromise. Why does that happen? Well, these patients have no difficulty inspiring. Their phrenic nerve is intact. They can take adequate tidal volumes. They can almost reach vital capacity breaths. Okay, but under these conditions, this is very similar to what happens from a pulmonary standpoint to patients that have a spinal anesthetic. Okay, what you've done is you've ablated the intercostal muscles, many of which aid in the process of expiration. Inspiratory efforts are not what is the issue here. It's actually expiration, and specifically forced expiration against a closed glottis, otherwise known as a cough. So these patients have a hard time coughing. So that's where they ultimately meet their respiratory demise. They're unable to clear their secretions. So they develop a post-obstructive pneumonia and a respiratory distress from that. So that's really the main effect of lower C-spine injuries from a respiratory standpoint. So again, hypotension can be common presentation in patients that are quadriplegic acutely. You may be able to better ascertain the cause of hypotension by placing central venous catheters and pulmonary artery catheters to assess intracavitary filling pressures and cardiac output. Of course, succinylcholine is something that you have to strongly consider whether or not it's safe to use for these patients. By the books, beyond the 24-hour range, it's largely considered contraindicated because of the upregulation of extrajunctional cholinergic receptors, which would release a lot of potassium in these patients. However, it's not a complete hard line in the sand as far as when you can and cannot use succinylcholine. A lot comes down to the degree of injury and whether or not the perceived degree of flaccidity may preclude the use of succinylcholine even earlier than the 24-hour range. But by the books, it's 24 hours. So which of the following is least likely to be seen in the trauma victim presenting with the accompanying chest x-ray? So the correct answer is decreased CVP. You're actually going to see increased CVP in this scenario. So this patient is exhibiting a pneumothorax. So if you look in this chest radiograph to your left side, or the patient's right lung, you see that well-demarcated area where the lung is separated from the pleura, from the chest wall, and that's where the pneumothorax is. So with tension pneumothorax physiology, you're going to have decreased preload because of that increased intrathoracic pressure. But as a result, because of that increased intrathoracic pressure, you're going to have a rise in CVP. And that's somewhat related to some of the physiology that we talk about with abdominal compartment syndrome in this next section. Abdominal injuries is a very broad topic, so kind of review it comprehensively in either Miller or Barish and some outlying external sources. It's a huge topic, so there's obviously a lot of injuries that can occur due to the unpredictable course of bullets and foreign bodies through the abdominal cavity. These patients are evaluated by CT scan unless they are significantly hemodynamically unstable. Overt signs such as tenderness, guarding, and gross distension of the abdomen may be present. Even in the absence of distension, that doesn't rule out internal bleeding. You can accumulate a wealth of internal hemorrhage before the smallest change in abdominal girth makes itself apparent. So the FAST exam, focus assessment with sonography for trauma, is typically utilized in the emergency room trauma bay. It has good specificity, moderate sensitivity. It's fast and very non-invasive, of course, and it takes a lot less time. It's certainly a lot less expensive than putting someone through a CT scanner if they're unstable. This is taken from Barish's clinical anesthesia. This offers you, on the vertical axis, all the variable diagnostic tools that may be used in the assessment of patients with abdominal injury, and goes over their advantages and disadvantages. It's pretty basic, pretty straightforward, but worth looking over at least once. Focus more on abdominal compartment syndrome. I would Google this and look at some of the physiologic derangements that occur with this particular syndrome. These patients present with a tense, distended abdomen, and one of the ways to diagnose this is to put an indwelling urinary catheter in and measure bladder pressures. Okay, pressures in excess of 20 to 25 millimeters of mercury indicate inadequate organ perfusion and necessitate abdominal decompression. Spend some time looking at all of these physiologic variables that are changed in abdominal compartment syndrome. For the most part, all of these should make sense to you based on what you would expect in a patient with a tense abdomen. Okay, I will direct your attention to the top left under the cardiac section, where it shows you that these patients have decreased cardiac output and decreased venous return, and that should make sense to you. With a tense abdomen, you're going to have decreased venous return due to the abdominal compression. And because the heart is pumping against a higher afterload, you have decreased cardiac output, as well as from decreased preload. However, the pulmonary artery occlusion pressure and CVP actually rise. So this is one of those rare situations where you have a rise in CVP and a rise in intracavitary pressures, but a drop in preloads. They're going in opposite directions. Usually the two go in the same direction, but this is, again, a unique example of where the two go in opposite directions.